Thank you for having me. And the topic for discussion today is, let me tell you a little bit about myself first. I'm a consultant based at the NHSBT, and I deal with three things in the NHSBT. And when I say three things, I mean we are all divided into silos, and I fit into three silos. So I do a couple of sessions for donor care, and I do a couple for red cell immunohematology, and a couple for the exchange unit, which is the therapeutic apheresis at the city hospital. So because I do all these three things, I'm in a position to see what is coming in and what are the problems at the donor end, what are the problems at the testing end, and how we can improve them. And of course, I'm able to see what is the demand because I deal with sickle cell patients. So with bearing all that in mind, I think I'll let you know that the topic today is rare donors, and you'd like to know who they are, why are they important? And I'm just going to tell you our experience, UK experience. I've been doing this job for about 20 plus years now, and I've seen this grow as I've, matured into the role. So let's take up the first slide, Emma, please. Right, who are rare donors? Now, basically, rare donors just don't mean red cell donors, okay? We've got rare donors with granulocyte antibodies for reagent use. You've got rare platelet donors. You've got rare plasma donors. We've got IgA deficient donors. We've got donors who we use for NEQAS, that is the National External Quality Assurance Scheme. And the topic today will be around rare blood donors. Though I deal with all these, but I'm going to be talking about red cell donors, because each of them, if I take up, is going to take, it'll take up the whole day if I start talking about each type of donor. So for today's discussion, we're going to focus on rare donors who are the rare red cell donors. Next slide, please, Emma. Now, rare blood. First thing about rare blood, what is rare in one country?
Nothing.
Sorry, could you mute yourselves, please? Right. So what is, you have to understand that blood groups are geographically distributed. And this is because we've not been in a position like we are today, where there are budget airlines and we keep flying from one place to the other, or the amount of immigration into this.
Oh, click mute, otherwise they'll be able to hear everything you're saying. Can't see your screen. Yeah, mute yourself.
Sorry, shall I continue now? Yeah, okay. So now these days, there's a lot of immigration going on in various parts of the world, and we are intermixing. But before, say, going even to the generation of our parents, largely what used to happen is that people in one country would marry their own in the country they were born, and that is how things were. With the result, what happened was, because these blood groups are genetically inherited, we have got rare donors which are rare in one country, may not be rare in another country. Because I can give you an example, like these days, of course, the problem of sickle cell disease is increasing in this country, but going back, say, even a century, if you looked at the Caucasian mix, the blood groups largely were the same. It's only this immigration of people from, I'm just giving an example of England particularly, that we've had different blood groups come here, and unfortunately, we've got an illness, which is an illness of the Black population, which is a sickle cell disease. And why are they called rare? Because they are rare as regarding the Caucasian population. If you go to Africa, you go to the Caribbean, these donors might not be, these blood groups might not be rare. I'll give you an example about the O negative, and I give it all the time because I experienced it myself. During the China Olympics, they did not have D negative blood. because D negative donors are not present in China, while you've got 15% of the Caucasian population as D negative. So what does it mean? It just means that either you are negative for something which is an antigen for which the rest of the population is positive, or you're positive for something which the rest of the population is negative. That's essentially the definition of rare blood. Okay. So the next slide, please, Emma. And the other thing I would say is that rare blood, genetically inherited, obviously, it runs in families. Now, what is the UK definition? Anything that occurs at a frequency of 1 in 1,000 or less of the population, okay? I said to you the same things which are written in the slide before, that what is rare for one ethnic population may not be rare for the other, and of course, genetic and geographical distributions. Next one, please. Now, what is the system of this, getting rare donors, and how do we manage it in the UK? The management is done by a team of medics and nurses. And all medics and nurses, they play a definitive role. It's like a chain and a teamwork that comes together at the end of it. The red cell immunohematology laboratory is very important and plays a very important role, and the International Blood Group Reference Laboratory. And these are a team of scientists. And they have the expertise to perform the tests and identify the rarity, identify the antigen. The National Frozen Blood Bank is also supervised by a medic, and the medic again works with the scientific team. There's work done by the scientists there. Now, I am somebody who is in charge of the UK. It's a self-appointment. It's happened because I've been doing it that long. But I look after the rare donors in the UK. And I'm also the international representative representing UK at the International Society of Blood Transfusion, the working party for rare cells. Okay. Next slide, please, Emma. You need to understand, how do we identify these donors? Now, as you know, when somebody donates, they donate blood, you, me, and everybody, whoever is a blood donor, they donate blood. The blood is put, just to give you a general idea, as soon as the blood comes in, the bags are taken to the issue department, manufacturing department, while the test tubes are run through a big machine, which is the Olympus machine, which does the red cell identification and the ABO blood group and the rhesus blood group. And that machine has got capabilities of us running 3 or 4 other channels as well, which, depending on the demand we do, also gives us the D type of the donor, and it does a very rapid antibody screen. So what happens when the donor comes in? Normally, we run through, I'll give you an example of how many donors we have a day. Birmingham is 10% of the country, and we have about 700 to 800 donors a day. So these many donors, we need a rapid throughput machine. So that's what the machine does. It gives us the ABO blood group, rhesus blood group, gives us the KEL blood group, and also gives us a brief antibody screen. So what happens? How do we pick up these rare donors? Anyone whose blood group we cannot identify, anyone who has a positive antibody screen, or any other thing where we feel that it is not responding to the needs of the machine, in the sense it's not giving us a clear-cut result, that sample is sent to the red cell immunohematology laboratory. And therein begins the journey of this rare donor now. Because for us not to get a result, there has to be something which is special in this donor. Not 100% of the time we find that it is something which is very interesting. This is one channel how we identify the rare donors. Once the red cell immunohematology performs the investigation, and they are not, if they're able to identify, or if they are not able to identify, if the sample goes to the International Blood Group Reference Laboratory, IBGRL, which is based in Bristol, and thereby we know what is special about this donor. Now, there's another way of identifying these donors. Next slide, please, Emma. Antenatal testing. As you know, that initially, of course, we used to do nearly 90% of the antenatal testing in Birmingham and a lot outside Birmingham as well. But since we've given it to the trusts, even now, whatever is not identified at this trust laboratory is sent to NHSBT. So women, when they are tested for antenatal testing, if they have an antibody which they've produced, which cannot be identified or which needs confirmation, it comes to the RCI laboratory and then goes forward to IBGRL if RCI are not able to confirm it. Thereby, during this process, we get to know these women who have produced antibodies to rare antigens. And that is one way of identifying donors. If these women are given a transfusion, we can't have them. If they are not given a transfusion, then we can have them as blood donors. And the way we do it is we write to the
Rekha, I'm sorry, you've been muted, I think possibly by accident. You'll need to unmute yourself. Sorry.
Yes, by accident, Susie, thank you. And thereby, once we identify these ladies and they agree to donate, we arrange for them a blood donor session and then they become blood donors with us. So that's the second way of identifying rare donors. Next slide, please, Emma. Now, how do we do it? Okay. In my experience, okay, this is not, I'm not taking it from anybody else's experience. What I do is I write to these donors and I have a discussion about the rarities with these donors, just trying to educate them and making them feel why they are important and how important they are. I think the key thing in running a rare donor panel is educate the donors, make them feel special and educate them. If you look at human nature, if I am told that I am somebody who can help a dying person or could help a lady have a baby if my blood is used in intrauterine transfusions, then I would invariably, 99% of the people come forward and say, no problem, if I can be of help, I'll help. But the problem occurs if they don't know what they've got. So education is the key point, and I must say to you, UK donors are very well educated. Our service is one of the best in the world, I can tell you categorically. Okay, next slide, please, Emma. Now, we have a process description. All of you might know that NHSBT, we run the whole show by SOPs, algorithms, and we have an algorithm how to pick up these rare donors. These algorithms, they automatically work and they direct the sample of these donors to proper laboratories. And how do we do this? What we have realized is, I've just given a lecture at the international level, and there were many countries who did not have this system in place and actually were very impressed with this system. And since then, I've sent our MPD to them. What we do is that we ethnically identify our donors at session. Now, this can go down very badly with donors because some donors might feel that, why are you asking us what ethnicity we are? And it's not, they feel discriminated. But you have to, again, educate them at that level and say exactly what I've said to you, that look, we are in need for donors like yourselves. Of course, we are in need with donors for the general pool, but we also run a rare donor panel, and rare antigens are geographically distributed. Thereby, we would like to put your ethnicity on the donor selection, the DHC, as we call it, the donor health check. Now, this NPD actually dictates, once the donation comes in, it dictates to the lab what samples have to be separated, what samples have to be preferably tested for what. Like, I'll give you an example. There's a blood group system. Red cells have about 300 antigens on them. And these antigens are divided into about 20 blood group systems, and some are not in the systems because these blood group systems are made according to the protein configuration of these antigens. So similar antigens are put together, and they might differ by adding a sugar onto them or something else. But what we do is the algorithm states, like if there's an Indian donor, there's a blood group antigen called INB. And INB negative donors are extremely rare. You don't find a Caucasian INB donor, but amongst the Indian population and the Pakistani population, because this is INB is the Indian blood group, it is 99% of them are positive as well. So it's 1% of the ethnic minority donations. And you know that ethnic minority donations are not that many. We're still struggling to recruit ethnic minority donors. So we explain to these donors that this is it, this is why we are doing it. Our system is working very well. I think it's largely due to the education of the donors. For example, an Indian donor comes in. We've got designation alphabetically, like from beginning from A, B, C, D, and so on and so forth. So this donor gets a code onto this testing slip, which as soon as they come in, and we know that we will test the donor for the Indian antigen. So it will go to the laboratory and be tested for the ethnic, according to the ethnic code. So you can't see the codes here, but this thing, which is a handheld phone, is telling you how many codes we are. It's not important for your purposes, but it's very important to us at the NHSBT. So if we get a coding that tells us this is a Black Afro-Caribbean donor, then of course the laboratory will test them for different antigens. And one of them is an anti-U, which actually is produced by U negative donors. And U negative donors I have not seen a single Caucasian U negative donor so far. It's always the Black ethnicity that has it. And I myself feel that, if I went to as a donor and I was told, you got to dictate, we want to know your ethnicity, it might seed in me something. Why are they wanting my ethnicity? Because there's a lot of myths among cultural problems and myths amongst the ethnic minorities. So we make it a point to educate them. And once we identify the rare donor, you have to believe me, I take a good 10 minutes, 15 minutes to talk to them, to explain to them the system, explain to them that they may be called, and they become so good. Some of them actually phone me before they come to donate. They will phone me because they know that donation is important. We have a frozen blood bank inventory where we freeze donations according to our needs. And the frozen blood bank every morning does a search as well, just in case a rare donors come and donated and we don't know that they have come. But these donors are also invited for specific patients. They know why are they being invited. And I'll tell you, 99% of them respond, and they respond very quickly. You'll be surprised to see that if you phone them in the morning, I've had donors who I phoned at 11 and they've come and donated at 1 o'clock. So such is the sincerity, and British donors are second to none. They are the best donors. Okay. Now, RO donations, RO donations are very important. These are largely because the Afro-Caribbean patients who come for sickle test, they all test as RO. RO is big D, little c, and little e. And if we don't have enough RO donations, we have to tap into our O negative pool, and that actually becomes a problem because we are recruiting O negative donors because of the high demand of O negative blood. And if we don't have RO donors, this is how it depletes it. Okay? Now, we've got a national testing process, okay, to increase the rare donors. And you will be, pleased to know, and rather surprised to know, that in the last 5 years, I would say, not even 4 years, we did a phenotyping audit, and we found that we were actually not following the algorithm to the final word, where that means we were not picking up the donors we were supposed to pick up. So testing department cooperated and they tightened the process. And you'll see that in last 4 years, we have increased the U negative donors to 25%. Now, my hematology colleagues will be happy to know that these days, when you ask for U negative blood, sometimes we are able to find it sitting on the shelf. Now, INB negative donors, to begin with, we had one donor. We also test families. Like because I do red cell immunohematology, and I identify that, of course, it's the scientists who identify, they just pass on the information to me. It's the hard work done by the laboratory. And if I come to know that this lady has produced an anti-INB, I usually request the treating clinician to take permission to contact her family and siblings. We test them, and we've now got 8 donors, and 4 of them were largely because a lady antenatally tested, and we found an anti-INB, and thereby her brothers and sisters came forward, and they were INB negative as well. Currently, I tell you, over 70% of the donations from ethnic minority are phenotyped. And we've had a 50% increase in 5 years for some very key antigens. One of them is the U and one of them is the INB. Next slide, please, Emma. Now, RO donations, okay. I'm sure most of you on the call know what RO is, but it's type, rhesus type. And it's the most common type, which is required by our Black minority patients. At the moment, our RO donors come from the Caucasian population more than the Black population because we do not have that many Black donors. There is a problem there. The problem is that the Caucasian RO donors do not have the same antigens, the other blood group antigens, as the Black donors. So this leads to a complication which is commonly seen in sickle cell patients, which is the alloimmunization. Because, for example, if an RO donor, who's say a Caucasian donor, comes and donate, he's definitely going to be U positive, okay? And the blood required by some of the Afro-Caribbean type is U negative. So then they make an anti-U. That is how the start of the alloimmunization begins. And gradually, because these guys receive so much blood, they receive about 8 to 10 units every 4 to 6 weeks. They get so alloimmunized that they become impossible to transfuse. And we have about 10 patients in this country for whom we keep 10 typed units in the frozen blood bank, just in case they come in crisis. And once they come in crisis, all 10 units go immediately. And then we have to start collecting again. And that is because they are heavily alloimmunized. So the white donors are the ones who are donating. NHSBT is working hard to recruit Black donors, but the problem of the home experience, I am an ethnic minority person myself, and I'll tell you that home experience doesn't leave you. In countries like India, where I come from, there are no voluntary donors. And basically, the understanding is, if I need blood, my relatives come and donate for me. The blood bank is there to do the cross match and the the testing of the blood. There is an improvement now. I won't say there isn't an improvement, but by large, if you or your relatives admitted, and it's the same in these. So what happens is, if I, as an educated person, think, okay, well, I know about blood donation, I should go and donate. The first question that comes to my mind is, what if my son needs blood tomorrow? I go and donate a voluntary donation today. My son meets with an accident, needs blood. I won't be able to donate, and I'll be begging relatives to come and queue up. So this experience actually just holds you from donating. And this home experience does not leave the ethnic minority, even in this country. They do not understand that this is a completely different ballgame. When you explain to them, they say, okay, that means the NHS has got the responsibility to supply blood. So why should we donate? NHS gets it. They don't understand. NHS cannot make blood. It has to come from you. So we're gradually spreading the message. And I would urge all of you to take this message from me, please, and help us out. Get us Black donors. And those of you who are dealing with sickle cell patients, at least in city, I make sure I tell them that please get us donors. And I know it's not the right way of recruiting donors. I do not pressurize them, but I tell them all the time to get their relatives, because that will increase the pool of Black donors. Next one, please. Of course, we supply blood overseas. And as I said to you, in UK, we are in a very good position now. We have supplied overseas many times. We do carry a very good reputation now. We've supplied to countries like America, at times have not had enough of their own blood. We collect the blood in the same manner. That is, first we look at the donations we've got. If we don't have the donations, then we start inviting donors. And what we do is exactly the same process is followed, but the only difference is that there is a very experienced team in Tooting blood center. So we send this blood to them. We have to communicate with them. And as I said to you earlier, that not everything is computerized. So even when a blood donor comes to donate, we have a tag on that donation, and that tag goes through collection, manufacturing, issue. And if that tag falls, we can have a problem in the sense if it's not identified as rare. It's happened many times. So we really, when a rare donor comes in to donate, we are on tenterhooks till we send the donation to Putin, and they tell us they've received it. And then they courier it to the requesting country. And I must say to you that since we've had the Brexit, we've sent blood to Ireland and we've had no problem. So I'm not seeing any problem regarding, still sending units abroad, at least to Europe. Next slide, please. Now, special call-up. Just giving you examples, and these two cases which I'm going to, I think there's another one here. This is a Pakistani lady who came to this country and was alloimmunized in Pakistan. Okay. Now look at the antibodies she had: an anti-D, anti-Duffy B, anti-JKB, anti-M, anti-S, and anti-Kel. She had the history of HDFN, that is the hemolytic disease of fetal and newborn. And this was a 5th pregnancy and had only one live birth. She came to the right country where the donors were really generous, very good. The system was in place. And we worked together with the fetal medicine unit in Birmingham. And you won't believe it, 9 intrauterine transfusions were given to this lady. There were 40 donations, 40 donors, which dwindled to 20 because donors are human beings like us. They travel, they have piercings, they have sex, and they have everything what we do. They're busy. They can be ill, and we ask them all sorts of questions. So basically, some of them failed the venipuncture, some failed the hemoglobin, and so on and so forth. So we dwindled to a list of 20. We call 2 donors at a time because if one doesn't, is not able to donate or for some reason fails a venipuncture or something, we have the second donation because we want to supply the blood just in case this lady has come to the fetal medicine unit. She's anxious, she's traveled, and we don't want to let down these patients because a mother is very anxious when she knows that the blood is going into her unborn baby and is going from, is going to help the baby. These ladies have to be explained a lot, and I'm sure the fetal medicine consultants do a lot of work, but we do our bit in the sense we provide the blood. We try and provide it. There have been hiccups, I must admit, but not many times. So this lady was given 9 intrauterine transfusions and she had a live birth in January. She had a baby boy. It didn't stop there. She was delighted with the outcome, so she became pregnant again, second time. So second time again, we went through the same process. I tell you, it was so hard. I couldn't have done anything without the help of Emma Watkins. Emma is a doctor, so Emma understands things. She works as my secretary. I don't know why, but she's a doctor. So Emma's help is crucial in what I do. And we managed this successfully and, of course, with a successful outcome. Next one, please. Next slide, please, Emma. Now, we get regular donations for this lady. This is a 53-year-old lady. She was 52, and I keep still saying 52. She's 53 years old. And she has regular red cell exchanges 6 weeks and requires 9 to 10 units per exchange. Now, we've given you the requirement. She receives R2, S negative, Kel negative, Duffy A negative, JKB negative, HBS negative, which is a requirement, and M negative. Now, this work, I must give credit to Emma. This is largely done by Emma. She looks at the donors just before this lady comes in and writes to them. And I actually supervise the work for this lady. I just can't do this. She does it every 6 weeks, and she's been carrying on for 2 years, rather 2.5 years now. So the credit goes to Emma. But we have managed to treat this sickle cell patient because of the phenotyping, which is now done so well in the NHSB. Next one, please. we basically, I'll tell you an indirect support which we've provided. There's a global shortage of an antibody called the anti-Lutherine A, and it's a shortage of the reagent at the moment. So I was in this group that was looking at the shortage, and I thought, because I'm an old-fashioned person working in the NHSBT, this is what we used to do years and years ago. I thought, why not look at an antenatal lady who has produced a very high level of anti-Lutherine A and ask her to come, we'll bleed her, and we will take the plasma and send it to the reagent laboratory to make the reagent. And initially, actually, it wasn't believed that it can be done, and people thought, okay, well, she's suggesting this and it can't be done. But we were lucky. I think I was very lucky. I was given 3 names, 3 ladies who had very high anti-Lutherine A in pregnancy. I phoned one of them and she wasn't available, but the second one was available. And this lady was very willing and she donated a bag of blood for us. And lo and behold, we have made the reagent. It's enough for the NHSBT for 2 years. I mean, England, Wales, and Northern Ireland, we can give them, all 3 of them can have. And as you know, this had to go to a commercial company. So there was a lot of ethical issues around it. And speaking to the lady and explaining to her what it was, she was happy with the procedure. And we had more. We supplied the 3 countries and we had more as well. So this is one example of, indirect patient care supporting diagnostic services. And this actually saves the NHSBT, a lot of pounds. I wouldn't say thousands because I'm not sure, but I was told that it's about thousands of pounds saved here. I'm not sure how much it was actually. Next one, please. Emma, next slide. Now, National Frozen Blood Bank, it's in Liverpool. And all autologous donations which we collect from very rare donors, we take a permission from them and we freeze them and say to them that if somebody else comes in and they need it, we will issue it. But we also explain to them that they're so rare, you will, who will use your blood? It has to be somebody like you, who's as rare as you. So it is mainly autologous. You will get your own blood. But if push comes to shove, somebody comes in, we will issue it. And we get to see an inventory and we plug in the gaps by calling in donors. It's managed by my colleague called Ulrika Polis. Now, we wouldn't like to use frozen blood very often because A, freezing blood is very expensive. B, we lose about 20% of the red cells when we thaw it. So if somebody needs 4 units, we have to thaw 5. And C, they have a very short shelf life once thawed. And D, there's a distance involved because it depends on how far you are from Liverpool and you have to basically adjust time limit in your procedure. You have to make that patient aware that it's going to take time, make the clinician aware it's going to take, rather not the patient, the clinician aware that it's going to take time for the blood to appear. It's going to be washed. It takes about 4 hours taking out the unit, thawed, washed, and sent by by either it's the NHSBT transport or a private transport, sent to the blood bank. Then it has to be cross-matched there and then issued. So it takes more time, and as I said to you, has a very short shelf life. So arrangements have to be placed, properly. As for a liquid unit, it can sit there and you can use it whenever you want to. Next one, please. Now I need to acknowledge people. I've acknowledged Emma. I've, acknowledged Ulrika. I also have to acknowledge the Wendy Nielsen and Eileen Bays. Eileen Bays and the Wendy Nielsen, they look after the donors and the donor experience team. There's the blood collection teams, the Tooting Hospital Services, donor records, all staff in the IBGRL and RCI and donor testing departments. And I'm forgetting many, many others who I keep bothering every now and again. And this is a multi-team effort and it works. This is a success story and we are able to look after rare donors. Thank you very much. One important thing which I say all the time is I've never seen such generous people I've been globe-trotting. I've worked in Africa, I've worked in India, and I work in England now, of course. Before this, I was in the Scottish National Blood Transfusion Service. I have never seen such generosity anywhere. We just send them a thank you note. A cup of tea is given to them with biscuits, and our standard of biscuits, I don't think, has improved in the 25 years I've been here. It's gone down rather. But these guys are just committed, and they come and donate. So without them, we can't do anything in this service. So great big thank you. The donors are the most generous human beings I've met. Thank you very much for giving me an opportunity to speak today. Thank you.